Good evening, everybody. On behalf of the Ceylon College of Physicians, you all are welcome to the second session of the new lecture series on peer learning periphery to the fore. This is an online case discussion by consultant physicians away from the center. My name is Dr. Rohit Amaravitarana, the moderator of the today event. This is 1 hour session and consultants working in outstation where they have resource limited setting will present and discuss clinical cases and share their experience with us. At the end of the both presentations, we will discuss the questions received from audience. Today we have two young specialists in internal medicine who are joining with us virtually from Nuwara and Dambulla. Let me to introduce first speaker today, Dr. Paboda Samaratunga, MBBS Peradeniya, MD Colombo, overseas training in Royal Hampshire Country Hospital, UK. Currently, she is working in District General Hospital, Nuwara as specialist in internal medicine. Her special interest is elderly care medicine. She is going to present a medical case of a young girl presented with prolonged fever. This girl presented to Base Hospital Mahiyanganaya, where Dr. Paboda worked earlier. Over to you, Dr. Paboda.
Thank you very much, Dr. Rohit. Before getting into my presentation proper, I would like to give a brief introduction about the Mahiyanganaya Hospital and also the situation where I work there. So actually during my short career in medical practice, I had a chance to work there in the Mahiyanganaya Hospital twice before going to my foreign training and after coming back from the foreign training. So Mahiyanganaya Hospital is actually it's a fairly rural, I can say the rural hospital, but it cater for large number of patients. Actually, patients are drained from from 5 districts of the country, and patients who are drained into the hospitals are underprivileged, as well as their education level also low. Most of them are farmers, and they are contributing to the economy in Japan. So coming into this presentation, this girl came to my ward during my last day in Mahiyanganaya Hospital, and she's 18-year-old girl from Padiyatalawa area, presented with fever, loss of appetite, loss of weight, body aches and pain for a month duration. She had a high-grade fever without any diurnal variation, no associated cough or sputum production, no any urinary symptoms or alteration in bowel habits, no joint swellings, but had arthralgia and myalgia, especially with fever spike. She has had excess hair loss for last few years, which has been increased during this presenting period. Going into her past medical history, she was apparently well until October 2019, where she has developed fever with thrombocytopenia and managed as dengue fever. Then found to have persistent thrombocytopenia during the follow-up, and she has been reviewed in Provincial General Hospital, Badul, and blood picture suggestive of viral infections with iron deficiency anemia. With that, she has been commenced on iron treatment, but defaulted follow-up. 1 year later, that is in August 2020, presented to Base Hospital Mahiyanganaya with multiple joint pain and heavy menstrual bleeding. Again found to have low platelet with the count was 88 according to her records, with normal other basic investigation. And she has been referred to gynecology team, as well as during the admission diagnosed to have ITP with blood picture evidence of large platelet thrombocytopenia with large platelet. Since then, she was under hematology clinic follow-up with multiple default clinic visits. She was not on any regular medication except oral iron treatment, which has been on time to time. Family history, there's a positive family history for hematological malignancies. One of her mother's sisters had a lymphoma. She's a schooling girl. She was awaiting advanced level exam. Elder child of a family of 3 children, and her mother was a housewife and father was a manual laborer. So with this history, when I examined the patient, she was febrile, had very high fever spikes, and had firm cervical lymph adenopathy, which were mildly tender. There were no any skin rashes, no peripheral stigmata of infective endocarditis. There were evidence of scalp hair loss. There were no any joint swellings or evidence of arthritis. Heart sounds were normal, lungs were clear, and there was a mild hepatomegaly. So with this history and examination finding, our differential diagnosis was whether this is an infection, either viral or bacterial. Can this be a hematological malignancy with the past history of persistent thrombocytopenia and the positive family history, and also whether this is an inflammatory disorder. So with this differential diagnosis in our mind, we started investigating her. So here I have to say that it's not easy to investigate parallelly for all those investigation in our setup in my Yangane due to low facility. So started with the basic investigation. So full blood count shows multiple pancytopenia. There also the platelet count is 63. And inflammatory markers during this stay in the hospital, CRP changed between 10 to 39, and ESR was 80 to 100. And her serum ferritin value was high. It was 1414.8, and LDH is 751. The MAN2 test was negative, and chest X-ray was normal. Liver function test was normal except marginally elevated ALT and the AST levels. Renal functions were normal. Urine full reports was normal. There were no any evidence of infections. During culture, there was no growth, and blood culture was no growth. Since she had a lymph node enlargement in the neck, we arranged the ultrasound scan neck. It shows multiple enlarged lymph nodes both sides of the neck, right side more than left. Most are reactive. Few altered lymph nodes in the right upper neck, most likely inflammatory. Then we arranged the ultrasound scan abdomen. It shows mild hepatomegaly, no intra-abdominal lymphadenitis. Small amount of free fluids were present in the pouch of doublet. We arranged a 2D echo from Badulla Hospital, which was normal. There were no evidence of infective endocarditis. That picture shows mildly hyperchromic microcytic with pencil cells. White cell count shows mild leukopenia, no neutropenia, neutrophil displaced mild toxic granules, few reactive lymphocytes. Platelets were moderately low. There were no any abnormal cells. So the comments was mild blood smears appearance of viral with the secondary bacterial infection. So at this point, when we are managing this patient, we wanted to clarify whether there's any evidence of hematological malignancy or whether this hematological malignancy. So after discussion with the consultant hematologist, she agreed to arrange a bone marrow biopsy for this girl. and it shows the aspiration shows appearance of reactive marrows, no features of hemophagocytosis. So there were no any evidence of hematological malignancy. Here the hemophagocytosis came into the doubt because she had a very high ferritin level and very high spiking fever with the organomegaly. And bone marrow aspirates and TB PCR, which was negative. Direct cum test also negative. Then we arranged the lymph node biopsy, which shows features of reactive necrotizing lymphadenitis, more favor of acute necrotizing lymphadenitis. So at this point, her features were not only can be explained with the Kikuchi disease. So I wanted to arrange the to see whether there's any evidence of connective tissue disorder. So it was very difficult to get done these investigations. There were no facilities in our hospital. So I discussed with the rheumatology team, Candy Hospital. Here I have to mention Dr. Tilaka Manil. Madam helped me a lot to diagnose this case, and they managed to arrange ADN. It was positive, and her BSDNA was negative. Complement levels was low C3 and C4 level. So this is the fever chart during the hospital stay. You can say that though I explained the investigation findings so quickly, but it took long time to investigate her because of the minimal facilities. So this point with this high fever spike and the investigations findings, we came to the she fulfilled the classification criteria to diagnose SLE. So because she had fever, hair loss, thrombocytopenia, low complement level. So with that, we came to the diagnosis of SLE plus Kikuchi disease of this girl. So coming into the management, since the admission, since it had a very high fever spikes with elevated inflammatory markers, I started the broad spectrum antibiotic with the possibility of sepsis. And raised with the rheumatology team Candy before starting steroid treatment, since we wanted to exclude any sepsis. In that point, I managed to arrange the procalcitonin level with the help of chemical pathologist in Badulla Hospital, and it shows positive procalcitonin level, which indicating severe sepsis. So in this point, it was very difficult to get a decision whether to start her on steroid treatment with this finding. So I discussed with Madam Tilaka Manil, and she advised me to start methylprednisolone pulse with the cover of broad spectrum antibiotic. Actually, she responded well to this treatment, and then she started on prednisolone daily dose with HCQ, and then later into azathioprine. Currently, after starting this treatment, she responded well and she felt better, and we managed to discharge her. And currently, she's following up at she's following under hematology team Vish Badulla, sorry, Mayangane, and rheumatology team National Hospital Kandy. So she managed to attend her studies, and she's currently doing her things well. So here I want to highlight one other point. Because of the parents' education level, it was very difficult to keep the patient in the hospital during this stay until we are finishing our investigations and treatment, because they wanted to take the child home. They thought that this is happening due to some evil power. So that's the attitude of the patient there in my area. So I had to discuss with the parents and convince them that this is something treatable and this is happening due to some ovary force. So coming into the discussion, Kikuchi lymphadenopathy or this is a benign self-limiting disease of unknown etiology that present with local lymphadenopathy, usually cervical, accompanied with fever, night sweats, and leukopenia. Kikuchi disease is an extremely rare disease known to have worldwide distribution with a higher prevalence among Japanese and Asian individuals. It has been rarely described associated with autoimmune disorders, mainly systemic lupus erythematosus, and its diagnosis can proceed post-date or coincide with the diagnosis of SLE. In our patient, it's an example for coincidence of this two condition, which is extremely rare. Coming into the pathogenesis briefly, it remains unclear. Various infections have been proposed, such as Epstein-Barr virus, human herpes simplex virus, hepatitis B, Parvo B90, human lymphoid virus 1, Yersinia enterocolitica, and Toxoplasma. This theory is based on the self-limiting force. Laboratory findings like atypical morphological lymph type on peripheral blood smears, as well as elevated inflammatory cytokines, interferon alpha and interleukin, and also the histological features, CD8 and plus T lymphocyte that includes the cell apoptosis. These cells undergo apoptosis themselves, which result in the necrosis background. However, the results are inconclusive, and it is not clear whether infections are responsible for pathogenesis. Other reports suggest an autoimmune origin because Kikuchi disease has been reported to simultaneously occur or follow SLE, like in our patient. So our patient also had criteria for SLE, as I explained previously. Other autoimmune diseases which can associate with Kikuchi disease are Stell disease, Sjogren's syndrome, polymyositis, and rheumatoid arthritis. So clinical features, lymphadenopathies are the most relevant manifestations. The cervical area is frequently involved site with severe pain or tenderness, but in our patients, there were no much tenderness in the lymph nodes, so only mild tenderness. Kikuchi disease usually present as solitary or multiple enlarged lymph nodes and rarely with generalized lymphadenopathy. Fever is another manifestation which is present in 30 to 50% of reported cases. Less common clinical findings include weight loss, malaise, chills, night sweats, or gastrointestinal symptoms. Investigations findings such as leukopenia, neutropenia, atypical lymphocytes, peripheral blood smear, thrombocytopenia, and anemia have been classically reported in Kikuchi disease. It is notable that our patient displayed pancytopenia, which is not commonly seen in Kikuchi disease and has rather been reported when SLE associated with Kikuchi disease. In addition to these, other biological abnormalities have also been reported, like elevated inflammatory markers, elevated liver transaminases, increased LDH, ANA, and low complement levels. Briefly about SLE, as we all know, it's an autoimmune disease resulting cells and organ damage, mediating tissue binding, autoantibodies, and immune complexes. Clinical manifestations are heterogeneous, and 90% of the diagnosed patients are female who are in childbearing years. More prevalence in Black and Asian women. Diagnosis of disease based on characteristic clinical features and autoantibodies. So these are the classification criteria to diagnose SCD. They are clinical and the immunological domains are there. With positive ANA titer, there should be at least 10 points out of these criteria. So our patient fulfill SLE classification criteria according to both CR and EULAR classification. So this is the end of my presentation. Thank you very much.
Thank you, Dr. Paboda, for interesting and excellent presentation. We will take questions from the virtual participants at the end of the next presentation. Thank you, Dr. Paboda. We will take questions from the virtual participants at the end of the next presentation. The next speaker is Dr. Arulanatham Kenneth, MBBS Peradeniya, MD Colombo, FCCP. Postgraduate training in acute medicine in Luton's and Dunstable University Hospital, NHS Trust, UK. Followed by elderly and palliative care medicine in Queensland, Australia. His special interest is acute medicine and infectious disease. Currently, he is a specialist in internal medicine working in Base Hospital, Dambulla. He is going to present a patient with unsteadiness and polyuria. Dr. Kenneth.
Good evening, everyone, and thank you, Dr. Rogide. So that as everyone is know that base hospitals are very much limited facilities, and we have a challenge to manage patients here. So not only the state expenses, patients side also they have to pay. They have to spend much more money to come to the conclusion. So I hope my case and its experience will help you for your clinical practice. So here that let's start. So a patient with unsteadiness and polyuria. So this is a case history of around 50-year-old gentleman who actually admitted to a hospital last December. And his hospital stay was 11 days. The duration is so long because of the difficulties to finding the investigation and some sort of management. So this is a 53-year-old gentleman presented with unsteadiness, increased thirst, increased urinary frequency, and very much irritability for five days duration. So he's a known patient with few comorbidities. You can see bipolar affective disorder, diabetes, and bronchial asthma with hypothyroidism. So he was on this medication for a long time. The collateral history from his wife, because the patient was very much irritable, unable to give a history. So the wife revealed he was apparently well for 5 days before, and then slowly he developed. He became lethargic, irritable, and poor intake. And then they noticed his walk was very much unstable, no hand tremors, and he started to pass large volume of urine for 5 days duration. So because of that, they brought him to the hospital and then denied any cardiovascular or respiratory symptoms. So no weakness or limb abnormality noted by the relatives. So in the past medical history, as I mentioned earlier, it's a bipolar affective disorder on treatment, and type 2 diabetes, bronchial asthma with a hypothyroidism. Another history, social history, is very much significant in this case because he's a very unsafe ethanol user and abstinent for last few days. So the patient was on this list of medication. You can go through on thyroxine, and there are a few medications for his bipolar affective disorder: clonazepam, rapidinol, and clonazepam. sodium valproate, sertraline, memantine, and lithium. So these are for his bipolar affective disorder. And for the diabetic part, metformin, glycoside, and he was on insulin also. So on examination, patient was afebrile, but very much disoriented, dehydrated, severely dehydrated. Vitals were stable. His blood pressure was 160/80, pulse rate with tachycardic, and no cardiac murmurs found. The lungs clear, abdomen soft, nothing else significant. So neurologically, actually, we couldn't perform neurologically because patient was very much restless. But significant hand tremor we noted. He was moving all four limbs, and then there was no lateralizing signs elicited. So because of the history and the examination, our initial thoughts were, could it be alcohol withdrawal? Because of regular alcohol intake and abstinence from alcohol for 5 days duration, that's possible. Lithium toxicity, actually every clinician usually thinking like that, because he was on lithium and he didn't follow for the psychiatric clinic for last 2 years because of the COVID situation. And the lithium level was not done because of, that for last 2 years, so everything disturbed. The underlying ongoing infections are the thought because of his diabetic and immunocompromised, so it's possible. So then we received the day one, we received some investigation. So out of these investigations, some investigation actually patients spend some money to get it done, specifically for potassium level. So WBC count, you can see WBC is a high, and then very much the serum creatinine is very high, the 13.9, and the blood urea is around 200. The potassium 8.9 is not compatible for the life event. And then liver enzymes not much significant, low calcium, and the ECG shows some tachycardia and blood sugar 262. So this is our day one investigation. So when continuing, we did an ultrasound scan because of very high serum creatinine. So it's suggestive of AKI and some fatty liver changes also. The troponin from outside not available in hospital. Sorry. So it came as a negative. Urine ketone body is not detected because he is a diabetic. So we thought it's diabetic related any emergency. So HONG or it's a diabetic ketoacidosis. So it's not detected. So lithium level is 10 because lithium have to do outside, and actually it took 3 to 4 days to get a report as well. So we did a venous blood gas that shows severe metabolic acidosis. So finally, basically this patient presented with severe acute kidney injury. So after the history and the first day investigation, our impression is it lithium toxicity? Very much lithium toxicity with AKI. Ongoing sepsis. Still, we couldn't prove whether any infection free of infection or not because his WBC is still high. The diabetes related emergencies still possible, but ketone body is negative. Drug overdose. He was on many medication and he was irritable, and then so it's still possibility. But our main concern was about lithium toxicity. So whatever the cause it is, he presented with acute kidney injury with very high serum creatinine and potassium level. So we started to stabilize the patient. So the initial management aim to hydrate him and manage the hyperkalemia and the metabolic acidosis. So a large volume hydration given, and then medically we managed hyperkalemia with dextrose, insulin, calcium gluconate, and then salbutamol nebulization, and then metabolic acidosis treated with IV bicarbonate infusion. So we started empirical antibiotic because of the diabetes related and then high WBC. So we started empirical antibiotic. The monitoring chart all initiated, vital input output sugar chart. So significantly we noted he started to produce a large amount of urine, 3 liters of urine, even though his serum creatinine was very high and the ultrasound suggestive of AKI, he started to produce a large amount of urine. So again, we liaised with the psychiatric team because of underlying psychiatric conditions. So they came and they have altered some medication. The lithium and nephrotoxic medications were omitted. So blood glucose we managed with the insulin sliding scale. So day 2 and day 3, so we prepared him for the hemodialysis. So thanks God, because we have a small hemodialysis unit, because the ampulla is highly prevalent for CKD people. So they are safe. 2 years before, or 2 or 3 years before, they started to function small dialysis unit, that purpose. So because of that, I think if I don't have dialysis unit, I was able to not manage this patient in the ampulla-based hospital. Should have transferred to somewhere else. So we initiated dialysis, hemodialysis. We gave a 2 consecutive hemodialysis. So that is each over 2 hours, 0 ultrafiltration, because of he was very much dehydrated. So day 2 and day 3, we dialyzed 2 times. So you can see the dramatic response of the renal function test. So serum creatinine from 13.9 to it dropped to 5.7. The potassium became 3.8. Blood urea 66. So the renal part, somehow we able to manage with the dialysis and other mode of medical therapy. But he continuously produced a large volume of urine. So it's not at around 8 liters per day now. So even though he is AKI patient, so we expected AKI patient uric or probably anuric. So he started to produce around 8 liters. On admission onwards, his urine output very high. So the question now comes, is the nephrogenic diabetes insipidus or recovery phase of AKI? So we all know that when patient recover from AKI, there's a phase for polyuric phase. Or is it like that, or is it nephrogenic diabetes insipidus? So nephrogenic diabetes insipidus is well-known complication of chronic lithium therapy. So the idea is, because of initially onwards, the patient producing large amount of urine. It's probably due to nephrogenic diabetes insipidus rather than recovery phase of AKI. So on the day 5, we received the lithium blood level. So we send this as day 1. So in the day 5 only, we receive the report. So you can see the report values, so 2.3 milliequivalent per liter. So the normal value is 0.6 to 1.2. So our patient's value 2.3. So you see this is a level, the toxic level, when is reached more than 1.5, severe toxicity 2 or more than 2, life-threatening more than 3. So our patient's range was around 2.3, is in between severe toxicity and the life-threatening. So the diagnosis we confirm is lithium toxicity related AKI, and because of polyuria, it's not a simple polyuria, it's more than 8 liters patient is producing. So patient developed diabetes, nephrogenic type of diabetes insipidus as well. So we offered him for 3rd hemodialysis on day 5 and 0.5 liter ultrafiltration over 3 hours. A large volume of hydration was continued to match his urine output. That was a problem, patient passing a lot of urine. So we need to match that one with the IV and the oral. On day 5, we noted his general well-being back to normal. So these are some reports, day 6 reports, and we send another repeat blood for the lithium level. So serum creatinine on day 6 was 1.9 and blood urea 52, potassium 3.6, almost is approaching the normal value. So it's now we confirm it's nephrogenic diabetes insipidus, but to make sure it's nephrogenic diabetes insipidus or it's differ from a cranial origin of diabetes insipidus. So we have to do certain investigation, as you all know. Urine specific gravity, plasma plus urinary osmolality, water deprivation test with vasopressin infusion, and the ADH level. So these blood tests, if you want to do in the one base hospital, is actually dream. So I didn't go through those things. So it's a clinically, we excluded other possibilities, and it's clinically it's a nephrogenic diabetes insipidus. So we try to manage the diabetic insipidus. So the day 7 patient was completely back to his normal, that is baseline, and he started to eat, good appetite and good sleep. Started to mobilizing him as well. So he was continuously producing large volume of urine. And then his day 7 blood counts, WBC count also started to drop around 11,000, hemoglobin stable, serum creatinine 1.6 and potassium 3.7. So to control the diabetic, nephrogenic diabetes insipidus, so I went to the literature and there are few methods they mentioned. Is one is a diuretics, HCT or amiloride, and other things, NSAID. So specifically Brufen. So the NSAID, this patient is contraindication because of AKI. So we initially started HCT and it doesn't work much. And then, so I changed to amiloride because amiloride is not available in and around the Dambulla. So the patient's relative, they got it from Kurunegala, is around 60 kilometers from Dambulla. So he responded to amiloride. It's a 5 milligram BD we initially started. He's responded very much to amiloride and his urine volume started to drop 3 to 4 liters within 2 days. So the second lithium blood level also we received on day 10, that was 0.6, that is normal, fairly normal, in the low normal level. And his day 10 serum creatinine 1.4, potassium 3.9. So everything is fine. So we prepared him for the discharge from the hospital. Family members had been educated about the diet and volume replacement and etc. So the question came, because this is my first case of lithium toxicity. So the question came, duration of amiloride therapy, how long we are going to give amiloride and when we are going to stop was a question. So I contacted Dr. Vasil, is a nephrologist, senior nephrologist in National Hospital Kandy. So he advised me to continue for 2 weeks and then stop. He said 2 weeks duration is enough. So we'll be back to normal. So day 11, we discharged him from hospital with his altered medication and then some health education. The patient was, then I reviewed him in a 1 week time with the reports, in a set of reports. So he was walking in actually to the clinic, walking in, stable mood. Serum creatinine was 1.1, potassium 3.7, blood fasting blood sugar of 123. So his urine volume was recorded at home 1.5 to 2 liters. So is everything fine? So we stopped the amiloride and we put on him the normal his routine. He was not on lithium and he's under MHU follow-up for his bipolar disorder. So it's just a short discussion. It's not much. So it's definitely we know this case is because of the lithium toxicity. But lithium having multiple beneficiary effects. So, so many things we are using, not only for the bipolar disorder, some nephrotic syndrome and some other, even in the literature they mentioned in Alzheimer's disease also, you can use the lithium. But the problem is this has very narrow therapeutic index, very narrow. So if you miss little bit, so it makes the condition worse. So clinically, 3 main categories of lithium toxicity observed. So it's acute toxicity, acute on chronic, or chronic. So acute manifestations are predominantly GI and may progress into neuromuscular signs. So that is GI mainly, they mention nausea, vomiting, and loss of appetite, so, sort of symptom. So acute on chronic, both GI and neuromuscular. The chronic one mainly predominantly neurological, that is tremor, that is like what our patient presented, tremor, ataxia, unsteadiness, hyperreflexia, and later on they develop hypothyroidism and renal toxicity. So in our patient is a chronic manifestations were there, that is neurological tremor, ataxia, and renal toxicity. So a little bit about the renal toxicity. They noted there are 4 types of renal pathology. So one is a nephrogenic diabetes insipidus, that is what our patient had. The renal tubular acidosis, chronic tubuloindustrial nephritis, and nephrotic syndrome. So nephrogenic diabetes insipidus is the most commonest and most worst scenario. So what's happening? The lithium inhibits the action of ADH on distal renal tubule. Because of that, patient develop polyuria and very much electrolyte imbalance. The management outline of the renal toxicity as what I did for a patient. So withdrawal of lithium, correction of electrolytes and acid-base balance, large volume of hydration. We had to match the volume according to the urine output. Hemodialysis to remove the lithium and to manage the kidney injury. So medication to control polyuria, NSAIDs, and diuretics. So before end, a take-home message for clinicians. So when you prescribe a medication to a patient who is on lithium therapy, be aware about 3 major classes of drugs which have been identified as potential precipitant of lithium toxicity. So we are seeing many patients in the private sector or in the clinical practice. Sometimes they may be on lithium therapy because of some mental health issues. So the starting some medication may interfere their lithium levels, and patient may end up with lithium toxicity. So keep eye on the diuretics. So it promotes renal sodium wasting. So what will happen when lithium level will increase in the blood with the salt wasting? So when prescribing the drug, we have to be careful. ACE inhibitors. So ACE inhibitors, we know they reduce EGFR, and because of that, enhancing the tubular resorption of the lithium. So thereby they can promote lithium toxicity. And the NSAID reduce the EGFR and interruption of renal prostaglandins. So these 3 group of medications can cause lithium toxicity. So be aware of that. These are the things I just want to share with you. Thank you very much.
Thank you, Dr. Kenneth, for very informative and interesting presentation. The next is the question and answer session. As we have not yet received questions from the audience, may I ask one question from Dr. Paboda? Paboda, what is the prognosis and the recurrence rate of Kikuchi's disease?
Actually, prognosis is very good. If a patient presented only with the Kikuchi disease, we need to follow up the patients to find out whether they are evolving into a connective tissue disorders like SLE, and recurrence is very rare. It's usually it says it's rare in the sense it's only it's occur once in the life.
Okay. Thank you, Dr. Paboda. And yeah. Dr. Kenneth, in your patient, we have seen patient was on multiple drugs. Was there any drugs which cause, which precipitate and potential precipitants of lithium toxicity in that particular list?
In that list, we couldn't identify anything for lithium toxicity. The issue is for last 2 years, because of the COVID situation, they lost the follow-up, and but they have taken the medication continuously, and lithium levels were not done during last 2 years duration. And same time, what we mentioned is when EGFR is going down, so he's a diabetic man, so taking insulin and metformin and metformin as well. So for some reason, and he's regularly taking alcohol also. For some reason, because of the drop of EGFR may precipitate this as well. But the clinical presentation suggestive of it's not very much acute, it's chronic. It's slowly gone for a long time, and then he become here. So there are lithium toxicity. There's an acutely happen condition as well as chronic also. So his nephrogenic diabetes insipidus and those things seems to like a chronic. That finally we have omitted lithium, and they have put on olanzapine also in addition to sodium valproate and other medication. So we omitted metformin because of that AKI. So we discharged him only with insulin initially.
Okay. Thank you, Dr. Kenneth. And so we are coming to the end of the sessions today. And first, let me thank two speakers, Dr. Paboda and Dr. Kenneth, for their excellent presentations. Also, I would like to thank virtual participants for joining with us today. Let me thank CCP staff, audiovisual team, Mr. Nalina, and sponsors, Merck Pharmaceuticals, for their valuable support. The next session of peer learning periphery to the fore will be held on June 2022. The date and time will be notified later. Thank you very much for joining with us. Thank you.
Thank you, everyone. Thank you.